thank you, Stuart, for having me. This is a wonderful learning opportunity. My disclaimer is that, yes, I am a clinician, and I'm one of those people that Stuart referred to as being new to metabolomics. So if I say anything incorrectly, you know why. So I'm going to talk to you today about, speaking of, the prior conversation about sort of multi-omics, I'm going to talk about the metabotranscriptomic signatures that we found in pediatric severe traumatic brain injury. So just to give you a quick overview, I'm going to talk about just some background on pediatric TBI, the pathophysiology, sort of how we currently approach it and what our limitations as clinicians are at the bedside. And then I will talk about the study that we just completed and data that we were getting back from that. So, and the study was actually done with in collaboration with many people in this room. So, so first, just the global burden of TBI. When you look at sort of the breakdown of all the common neurologic disorders, traumatic brain injury has the highest incidence of all of them. So 50 to 60 million individuals per year globally. It's estimated to remain one of the top 3 causes of injury-related death and disability up until at least 2030. It has a substantial public health burden, so $400 billion a year is the estimated cost, and children in particular. So ages 19 and below have the second highest rate of hospital admissions, and with the first being elderly adults, so people over the age of 65. It is the leading cause of death and disability in children greater than a year of age. And then I'll talk just briefly about sort of the pathophysiology. So when we think about TBI, there's obviously the traumatic impact that occurs first. So the traumatic impact is thought to be sort of the primary phase of injury. That's, the head gets hit, brain injury occurs, and that's the coup injury. The opposite side of the brain can also get injured from just movement of the brain against the skull from that traumatic impact, and that's the counter coup injury. That's all a part of that primary event. Unfortunately, that's not where the injury stops. So in the minutes after that primary event occurs, in the minutes to hours to days, there's sort of a cascade of events that occur. And that includes this sort of overexcitation of the neurons and therefore excitotoxicity, massive glutamate release, calcium influx into the cells. You have mitochondrial dysfunction, breakdown of the blood-brain barrier, release of a lot of pro-inflammatory cytokines, and massive immune activation. So all of that is sort of occurring, and to steal the words of Dr. Doak earlier, it's kind of a continuum of crisis and it's specifically a metabolic crisis that occurs in the brain for days. And because of this time frame, though, it does also create an opportunity for potential therapeutic interventions. So this is what a child might look like in our ICU. They are connected to 1 million monitors such that they become almost unrecognizable to their families. All these images to the right of the screen, these are all the many of the modalities that we can use just to monitor the brain. So I just wanted to point this out because even though they're connected to all these monitors and we're monitoring a lot of different physiologic endpoints. So we can monitor blood pressure, we can monitor their intracranial pressure. Because of all that those inflammatory events that are happening in the brain starts to swell. So we can put a monitor in and measure the intracranial pressure. And we do all the things that we can from a medical standpoint to minimize that pressure. We can measure the pupillary reaction, the rapidity with which the pupillary reacts gives us information. We can do ultrasounds to measure the cerebral blood flow, but despite this, there's still a gap between what is happening up at the cellular level and what we can measure at the bedside. So all these physiologic endpoints, we might be seeing these clinical events occurring that may be too late or might not even be the correct physiologic targets. So a couple of these monitors are a little bit more getting into what's happening at the cellular level. So there's a brain tissue oxygen monitor where and then there's a cerebral microdialysis monitor. I'll mention those again in a second. So when the patient comes to us, that primary event, the trauma has already occurred. There's unfortunately nothing that we can do about that. Our job now is to minimize that secondary phase of brain injury as much as possible and protect the brain as much as possible. So what do? We make sure that all the sort of the basic functions are remain physiologic. So we optimize their blood pressure. We make sure their oxygen levels and their carbon dioxide levels are normal. We try to prevent that brain swelling as much as we can and minimize intracranial hypertension. And then we try to avoid adding insults onto injury. So we make sure their blood pressure doesn't get too low. We make sure their electrolytes are normal. We make sure they don't get hypoxic. If you notice, though, all these things that we are doing are supportive measures. None of these are actually getting to the underlying pathology that's happening at that cellular level. So, TBI is one of the traumatic brain injuries, one of the most well-studied neuropathologies that we have, and there's still no targeted interventions that we can give at the bedside to treat the underlying pathology. There have been, over the last couple of decades of research, more than 30 clinical trials of pharmaceutics to treat traumatic brain injury, and the U.S. Food and Drug Administration has not been able to approve any of them. And there's often a disconnect between what we see in the preclinical studies. So there might be therapies that look very promising on the preclinical side, and when they're put to clinical trials, they're not successful. So I mentioned a couple of the more invasive monitors that we have. So brain tissue oxygen monitors and cerebral microdialysis monitor, where we can measure the CSF metabolites. Those are actually coming more into the precision medicine, concepts or analyses. The problem with those is that they're invasive. So it requires a separate catheter to be placed in a child's brain in order to measure these things. And nobody wants to do that if they don't have to. They also measure only that focal pathology. And so if you have, if you have focal pathology, if there's only one area of the brain that's affected, that might be okay, but it doesn't actually help us address other types of more heterogeneous pathology or diffuse pathology. So in particular in TBI in general, but also in particular in pediatrics, there are a few key barriers that we have. So one is just, what are the morbid factors that the patient's coming in with? So what are their genetics? How are their genetics informing their response to insults or this trauma, environmental factors, et cetera. Kids are also at different ages and stages of brain development. So if a 4-year-old accidentally gets hit with a softball in the head versus a 16-year-old gets in a high-speed car accident, those patients both have severe traumatic brain injuries, but their responses to those injuries might be very different based on the injury itself, so the type of traumatic insult and the magnitude of it, but also just their ages and their genetic preconditions. But at the bedside, when we as clinicians are taking care of them, we approach their treatment almost exactly the same, and that might not be appropriate. So different pathophysiologic processes might be occurring in different patients from the same injury, the same type of injury, or in different stages in the same patient along their trajectory, or in different regions of the brain. There have been some recent advances in traumatic brain injury research. So for instance, we do get a lot of information, a lot of helpful prognostic information from imaging. So CT imaging and MRI imaging, recent studies in these blood-based biomarkers. So GFAP, neurofilament light protein, S100 beta tau. These are helpful from a diagnostic standpoint and somewhat from a prognostic standpoint. And for instance, there's a lot of study on these markers in sports-related concussions and return to play protocols, et cetera. Genomics, there's more and more genomic studies occurring now. So it's thought that about 26% of the variation that we see in outcomes is actually related to their genetic predisposition. Metabolomics. So there are preclinical studies in TBI models, animal models, and then there are very few adult studies that are actually now starting to be published, and I'll talk about that in a second. Transcriptomics. So there are also some preclinical as well as adult models, or adult studies that have been published recently. From a metabolomic standpoint, the adult studies that I've seen so far talk a lot about the changes. So there's changes in lipid metabolism in particular after injury, We also see impaired glucose metabolism and mitochondrial dysfunction. And they're able to use these metabolomic signatures to differentiate between mild TBIs versus moderate to severe TBIs versus the healthy patients that we compare them to. And then those specific signatures can also correlate with the imaging findings that we see post-trauma, as well as the outcomes that have been measured so far. And so far, there's been up to 1-year outcomes that I've seen. So in pediatrics, though, we have not found any studies looking at this so far. So there's no note that we are not aware of any metabolomic or transcriptomic studies in pediatric severe TBI. So our goal in doing this study that we just completed, it was to identify signatures that may reflect some of those cellular and metabolomic or mechanistic changes that happened at the bedside that we can't necessarily see when we are taking care of these patients clinically. So we did a prospective observational cohort study evaluating the transcriptomic and metabolomic signatures comparing two groups. One is the severe traumatic brain injury population versus healthy controls. We included pediatric patients, so ages 1 to 21, with severe TBI. So when we say severe, we categorize the severity of traumatic brain injury based on what we call the Glasgow Coma Scale or the GCS scale. And that's sort of a gross measure of like a neurologic exam based on their verbal response, movements, and eye-opening response. And so if you have a GCS, it's up to a 15-point scale. If you have a GCS of 8 or less, you're considered to have severe traumatic brain injury. We excluded patients with any significant comorbidities, if there's any chance that you're pregnant, or if you had non-accidental trauma or abusive head trauma, which unfortunately we do see a lot, or patients in which the mechanism of injury is unclear. So we enrolled 17 TBI patients. So these patients, we got blood and urine samples from them at 3 different time points. So the first time point was within 12 hours plus minus 24 hours, or 12 hours. So about the first 24 hours of injury was the first time point. The second time point was 48 hours plus minus 12 hours. And then the third time point was the day 9 day 9 of hospital stay. The thought being that the first 2 time points are going to be that period of acute secondary brain injury where those injurious processes might still be occurring, with the third time point being theoretically the patients on the recovery side of things. Then we enrolled 10 control patients that we tried to age and gender match as well as we could. So our clinical and demographic data where we got from the chart, and then we're actually still collecting our 3-month outcomes data. So these samples were sent to third-party vendor for the RNA extraction and next-gen sequencing, and then Jeremy Prokop is his lab or is the person who helped with our transcriptomic analysis, and then Stuart Graham's laboratory for metabolomics analysis, and Yossis Gordovicius's team from Vugene for combined transcriptomics plus metabolomics analysis. This is the RNA sequencing workflow that the Prokop lab used, and their analysis included matching reads to human genes using salmon quasi-alignments, and then matching to bacterial and viral RNA using Kraken-2. They looked at the immune repertoire as well as cell-free RNA. And then this is a picture of just showing the metabolomics workflow and Dr. Graham's lab members in action. So they use proton NMR and targeted mass spectrometry using the biocrates Q500 XL kit. These are complementary analytic techniques that are fully quantitative. And so the results are somewhat just hot off the press, and we're still sort of digesting all of it and trying to find patterns. And I'll talk mostly about 2 more notable findings that we have found so far. One is the granulopoiesis pathway. So granulopoiesis is the process by which our bodies give rise to white cells, specific types of white cells, which are called granulocytes. Primarily, granulocytes are neutrophils, basophils, and eosinophils. And it is it's demand driven and adaptive. So our bodies make more in response to, for instance, injury or illness. And neutrophils in particular are a type of white cell that is it's the most abundant, and it's thought to be sort of the first responder to injury or illness. And neutrophils contain granules that the molecular contents of which, when they are released, so neutrophils get incited to a certain injured area. So demargination, so they get demarginated, they degranulate, and then they release their contents into their environment, which can cause both harm as well as help. So in a normal, like sort of control state, we're all happy and healthy. There's generally a single population of mature neutrophils that are circulating in our blood. In a post-traumatic brain injury, there's a significant release of immature neutrophils that get released into the circulation. These are highly recruited to the injured parts of the brain, and it contributes to that whole process of inflammation. The inflammatory cytokines, reactive oxygen species, proteases, and so they can be mediators of early secondary injury and play a role in determining patients' long-term outcomes. When we looked at our data, so this is showing, I don't know if you can see that very well. This is just to show, this is a normalized enrichment score of the 20 most significant pathways. And I'm just showing this to show that the neutrophil degranulation gene expression pathway is significantly upregulated. So this is not new. This is consistent with what has already been published. This is what we know happens after traumatic brain injury. What we found, though, that I haven't seen published or described yet, is that when we looked at so that's what happens with the sort of the neutrophils that are already circulating within the body. The granulopoiesis pathways, though, this is a clustering of pathways from an overrepresentation analysis from our control group. So you can see that these are the gene expression pathways that regulate granulopoiesis. And so this is in sort of the normal healthy individuals. And what we found in our TBI population is that particularly in the first 2 time points, the granulopoiesis pathway is significantly downregulated. So presumably, they're not making new white cells in the way that the control patients are. So that transcriptional control, or the gene expression pathways of the metabolites under normal conditions after TBI, is maybe lost or deficient. So why is that happening? This is the first time that I have seen this described. So could it be a potential therapeutic target? I think we don't know yet. So the things that I think about is, could this be a normal sort of negative feedback mechanism where there's a lot of neutrophil demargination, degranulation already happening, so that the body says, okay, I don't need to make more white cells. I don't need to make more neutrophils, but, or is it a pathologic response? Somebody had mentioned that the brain is immunologically sort of privileged because of the blood-brain barrier, but post-traumatic brain injury, the blood-brain barrier is disrupted. And so what does that mean in terms of the crosstalk between the systemic immune system and an injured brain? What we do know is that there is a body of literature that shows that after severe traumatic brain injury, patients are more susceptible to hospital-acquired infections than other patients. And so could this be a pathologic response? Another interesting thing that's emerging in the literature is that it used to be thought that neutrophils are sort of a terminally differentiated cell, where if you get injured, if you get ill, they sort of mature, or even immature cells will sort of go to the site of infection, do their thing. But we're now finding that there are various phenotypes of neutrophils. So there's certain neutrophil subsets that actually can be take on more of an anti-inflammatory role or a protective role after injury or illness. And so how do those different subsets of neutrophil phenotypes affect a traumatically injured brain? And can we somehow leverage this lack of granulopoiesis or this maladaptive response? Can we sort of alter that and make use of these more helpful neutrophil subsets? So that's one interesting finding from our data. Another one that I'll talk about briefly is this the indole pathway that also our Dr. Doak had mentioned earlier. So indole 3 propionic acid is it's found in normal gut flora. It's a metabolite that is that occurs by metabolism of tryptophan by a number of bacteria, the most common type of bacteria, which is the Clostridium species. So tryptophan is metabolized through this pathway to make IPA. So IPA is actually found to be a very strong, has potent antioxidant qualities as well as anti-inflammatory qualities. It stimulates the expression of tight junction proteins to enhance barrier function. So specifically the gut-blood barrier is helped by this IPA molecule. It can also cross the blood-brain barrier. So from a neurologic standpoint, it can help prevent lipid peroxidation. It can help DNA damage in the neurons. It inhibits gliosis or glial scar formation and enhances axonal recovery and mitochondrial respiratory function in the brain. So what we found in our data was when we looked at the transcriptomics and metabolomics analysis, we found that there were pretty pronounced metabolomic alterations in the TBI patients as compared to our control patients. So in the control group, this is I don't know how well you can see that. This is the Circos plot. Can you guys see my mouse? Wait. Oh, I'm just gonna, so in this Circos plot, these are the differentiated expressed genes, and these are differentially expressed genes, and these are the differentially abundant metabolites. Oh, thank you. Perfect. Thank you so much. Differentially expressed genes and then differentially abundant metabolites, and these these are the associations. So with the red lines being positive associations and the blue lines being negative associations. So you can see in the control group, I'm going to point out this 3-IPA right here. You can see that 3-IPA is pretty abundant, and it has a lot of gene associations. In the TBI group, so this is our last time point. This the 3-IPA here is the abundance is much less, and the gene associations are also much less. So and you can see this when we look at all 3 time points, you can see the progression of IPA becoming less and less over the course of their illness. Just knowing the neuroprotective effects of 3-IPA, this could be notable, and it could be, a potential therapeutic target. I have not found this to be, there is one adult study that also describes 3-IPA abundance being much more decreased than controls in the adult TBI population as well. So why does this happen? Could there be a gut dysbiosis? We've been talking about the sort of gut-brain axis. Could there be a gut dysbiosis after traumatic brain injury that could explain this? Could this also be worsened by the things that we do? So there is literature to show that one of the most common antibiotics that we use, so vancomycin, this is made by a bacteria, the Clostridium species. These are gram-positive bacteria, and the vancomycin is one of the most common antibiotics that we use, and it targets gram-positive bacteria. So of course, you give vancomycin to all of our patients, almost all of our patients get this, and so it probably wipes out their 3-IPA or their IPA molecules. So I think there's a lot of questions that come up now with this data. It actually, IPA is now being studied in various diseases. So inflammatory bowel disease, type 2 diabetes, atherosclerosis, Alzheimer's, and breast cancer. So I do think there's a potential for enhanced neuroprotection if we can somehow leverage this finding. Just the limitations of our study, obviously one is a small sample size, so we just need larger scale studies. And it was our just single center, and we have, a specific approach to TBI patients, whereas others might not have the same approach. So that's of course going to be a limitation. We had predominantly males in our sample population. Males are the incidence of when you look at the incidence of TBI, there's always going to be a male predominance there. And then, you know, we were limited to serum metabolites, and that might not necessarily reflect what's happening in the cerebral metabolism. And of course, it's going to be impacted by all these other factors. So to me, those are some of the limitations. In terms of future directions, like I said, larger scale studies to look at this, and how can this not only enhance our diagnosis and our clinical decision making? Can we predict? Are there ways to predict how a certain patient is going to respond to our therapies and then progress? And it's very difficult for us to prognosticate and tell parents this is how your child is going to do, because there's so many factors, and we really can't predict. And so I do think these types of omic studies are going to be very important for us in the future. Again, understanding the gut-brain connections. The last thing I'll say is just, I believe that, you know, children who come into any child who comes into the pediatric ICU, whether they have brain injury or not, their neurologic outcome has the largest impact on their quality of life. And there's about 145,000 children living with the long-term sequelae from TBI, whether not just physical disabilities, but social, behavioral, cognitive disabilities as well. And children have the lowest, when you look at all TBI, children have the lowest mortality, but the burden on their lives is significant. And so for every 3,000, or the burden of death is significant. So for 3,000 TBI related childhood deaths per year, that's 200,000 years of lives lost, or years of life lost. So just more targeted treatments for this population. I think these types of conversations and this type of study is going to be really important for clinicians moving forward. I'm happy to take questions.